Hello everyone. Thanks to the Azerbaijan Society of Anesthesiologists for the invitation and for this amazing organization. Also, thanks to everyone who joined us today. I'm honored to be here as a speaker. I'm Dr. Tural Alekberli, staff anesthesiologist in Canada, working at the Edmonton Regional Hospital, part of the Vitality Health Network, affiliated with the University of Sherbrooke. I'm subspecialist in regional anesthesia and pain, also in obstetric anesthesia. Completed both fellowship at Mount Sinai Hospital, University of Toronto, worked there for 2 years. I got my specialty of anesthesia from Israel, Hebrew University Hadassah Hospital. I'm editor of 2 anesthesia and critical care international journals, and I'm a founder of Smart Anesthesia software. You can scan this QR code to find more information and details about me if you have any question. First of all, I must mention that I have absolutely no conflict of interest in this presentation. I want to acknowledge the New York School of Regional Anesthesia, known as NYSORA, and especially Dr. Admir Hadzik. I admire his achievements in regional anesthesia. I always use their tools, videos, applications, and website, and I have used lots of images and illustrations from the NYSORA for this presentation. By the way, I want to also invite you all to NYSORA's traditional Leuven Anesthesia Summit, which will take place in Leuven, Belgium next year between June 14 and 16. I'm invited as a speaker to this summit, and I will talk about knee replacement surgery anesthesia techniques, single shot and continuous nerve catheters, especially the new iSafe technique which we developed in the University of Toronto. Now, let's dig into the exciting topic, rising star of the anesthesia, ultrasound guided regional anesthesia. We can't talk about ultrasound guidance in nerve blocks without mentioning these 2 universities. In 90s, University of Vienna was the pioneer on using the ultrasound for nerve blocks, and they have started femoral and brachial plexus block initially. Then University of Toronto did well-organized research and took the project in a different level, advanced and started many other new techniques. I had chance to meet, learn and work with some of those brilliant minds in Toronto. So what are the alternatives to ultrasound? Regional anesthesiologists were using previously some surface anatomy-based techniques, palpation of landmark, facial clicks, prosthesia, and nerve stimulation. While the peripheral nerve stimulator has been a reliable tool for nerve localization in peripheral nerve blocks, the increasing use of ultrasound has questioned this ongoing role. A study by Peripheral et al. From University of Toronto a decade ago found that even when visualizing the needle tip on the nerve surface with the stimulator set to a 0.5 mA or less, motor stimulation occurred in only 25% of cases. This highlights a potential limitation in relying solely on the peripheral nerve stimulation in the era of ultrasound-guided procedures. The stimulator, in addition to ensuring block efficacy, acts as a safety monitor during ultrasound-guided regional anesthesia. A threshold below 0.2 mA signals accurate needle tip placement within the nerve, making the stimulator valuable for safety checks, especially when deep nerves or less precise ultrasound images warning against potential issues with local anesthetic injection. Now that we have advanced technology, large sophisticated machines along with the pocket-sized practical wireless devices, there is no need to do any of these procedures blindly. Ultrasound guidance offers a number of important practical advantages for nerve block. Ultrasound allows visualization of the anatomy of the region of interest. This allows more informed guidance for the needle pathway to the target while avoiding structures that might be damaged by the needle. Ultrasound also allows a visualization of a needle tip as it is passed through the tissues, confirmed alignment with the intended path, against reducing the likelihood of inadvertent needle trauma to unintended structures. Perhaps most important, real-time ultrasound imaging permits continual visualization of local anesthetic solution delivery to ensure proper distribution, with the potential for adjustment of the needle tip position as necessary to optimal local anesthetic distribution. Introduction of ultrasound guidance in regional anesthesia has led to the refinement of many nerve block techniques, expanded use of peripheral nerve blocks, and greater acceptance by surgeons and patients. Ultrasound guided peripheral nerve blocks may be broken down into two fundamental aspects: imaging structures in the plane of section, including the target nerve, and guiding the needle. Understanding the recognition of three-dimensional anatomic structures on a two-dimensional image requires training in the technology and sonoanatomy pattern recognition. Here are some tips for optimal image visualization with ultrasound. First is choosing the right probe for the case. The case, I mean the block you plan to perform and also the patient that will receive it. For example, even though the high-frequency linear probe is usually appropriate for a ductal canal block, you cannot get a good image when you have a patient with a BMI over 50. Lots of fat tissues are on the way, and you will need a very deep image, so switch to a curvilinear low-frequency probe to do the procedure. Of course, you must understand underlying anatomy. You cannot and should not perform nerve block without knowing the anatomy. What vascular structures should be expected, bony structures, and sometimes pleura on the screen. Regional anesthesia providers are usually make it seem so easy to do when you watch. However, it is the result of knowledge, skills, and experience altogether. Say that, the rest of this slide points are actually skills. The adequate pressure to the tissue, for example. With the adequate, I mean enough to see the clear image, but not to collapse and hide the vascular structure. You must see the vascularity around. Also, aligning the probe with the target nerve is crucial. You need to understand the three dimension of the anatomy. Lastly, rotation and tilt are two fine skills that help us to get the best image. In this example, you can clearly see better the image can get with the fine tilt of the probe. Here in this example of the supraclavicular brachial plexus block, I wanted to highlight the importance of the Doppler function of the ultrasound. As you can see here, among the brachial plexus nerve structures, they are very similar looking structures until you perform the Doppler. It turns out that it's not the nerve bundle, it's the artery. Knowing this information will definitely change your needle guidance. About the needle guidance, I want to highlight some points here. For better needle guiding, you should utilize a shallow angle of approach. If possible, heel the transducer to make the face more parallel to the needle. Rotate the transducer to ensure the entire needle is seen on the screen. Tilt the transducer as necessary. Needle selection is also important, so choose an echogenic needle if possible. Also, hydrolocation may help a certain needle tip location. Inject a cc or maybe a half cc of medication to visualize the needle tip. Apply needle recognition software if available. Some ultrasound devices are smarter than we think. They can provide better images with steep needle function. In this example here, this is an almost 10-year-old machine, and those dots are indicators of the steep needle function. Just try to learn your machine better. So the patient and ultrasound machine positioning are also crucial. Appropriate adjustment of the bed height and ergonomic placement of the ultrasound so that operators' eyes can easily and rapidly shift from the image to the field. where the needle alignment with the long axis of probe can be ensured is beneficial. Every block procedure have a different patient positioning that can work for you better. You must learn your best position after trying what works for others. For example, the popliteal sciatic block. Some do it in prone, some lateral, and some in supine with 90 degrees bended knee. So you need to choose your way of doing blocks. While different tissues have characteristic appearances on ultrasound, nerve may not be easily distinguished from tendon when both are viewed in short axis. However, using knowledge of anatomy, the operator can follow the course of the structure, caudate cephalid, to determine the nature of the structure imaged. The tendon will eventually disappear into the muscle of origin or insert into bones. A good example is here, median nerve at the wrist left side, where it is difficult to discern the neural structure from the many tendons in the carpal tunnel, versus in the mid forearm right side, where the nerve is much more visually distinct as it is situated between two layers of muscle with no surrounding tendons. Very briefly, I'll just mention the usual nerve block which can be performed under ultrasound guidance. So the upper extremity, we have the most important player, brachial plexus, also called the spinal of the upper extremity. We can block the plexus at the different levels depending on the procedure, interscalene, suprascapular, intraclavicular, supraclavicular, axillar levels can be used for blocking the plexus. Also, radial, median, and ulnar nerves can be blocked separately depending the procedure. From the lower extremity, we can mention lumbar plexus, femoral nerve block, fascia iliaca, suprainguinal and infrainguinal levels to cover femoral, obturator, and lateral femoral cutaneous nerve. We can block lateral femoral cutaneous nerve separately. Sciatic at several levels, popliteal, subgluteal, saphenous at adductor canal, femoral triangle, and ankle block. Truncal blocks can be more challenging. Paravertebral and ESP, also deep quadratum lumborum block, will require more experience to provide accurate blocks. PEX 1, 2, and serratus are increasingly used for breast surgeries. Increased usage of thoracic epidurals for open abdominal surgeries limited the use of abdominal blocks. However, for patients with anticoagulation or any kind of contraindication for thoracic epidural, truncal blocks at abdominal level are considered a good alternative. Top block, rectus sheath, and quadratum lumborum blocks can be mentioned here. In general, I want to mention also one point which in my opinion is crucial for anesthesiologists to know when not to perform the block, when it is not necessary. Understanding the nature of the surgical procedure, communication with the surgeon can change your plan. For example, when you have a listed case of resection of the tumor from tibia and fibula, it can be a huge sarcoma of leg which may need a femoral and sciatic nerve block catheters for a proper post-op pain management, and it might be a small benign soft tissue tumor which patient may be planned to go home same day. Your plan is in this case maybe just a short GA with no regional anesthesia procedure. Not to block patients' motor functions and allow faster recovery. Communication with the surgeon and patient is crucial for planning. Choice of the local anesthetics and adequate volume for the procedure are also key points for us. The efficacy of ropivacaine is similar to that of bupivacaine for peripheral nerve blocks. Studies prove that clinically adequate doses of ropivacaine appear to be associated with a lower grade of motor block than bupivacaine. Thus, ropivacaine with its efficacy, lower propensity for motor block, and reduced potential for CNS toxicity and cardiotoxicity appears to be an important option for regional anesthesia. We usually use 0.5% for analgesia and we decrease it to 0.25% when we need more volume. We always add epinephrine to our solution to prevent accidental vascular injection. Dexmedetomidine is proved to prolong the block time, but its price can be sometimes limitation, so it might be beneficial to use for specific cases. There are still debate of using dexamethasone IV versus in the local anesthesia solution, but studies shows no superiority one to another. And I like to use it IV so I can benefit the other effects of dexamethasone like antiemetic effect. Volumes for the blocks are various. We usually use 15 to 20 cc of local anesthetic solution for plexus blocks and large nerve blocks like femoral and sciatic, etc. 30-35 cc, sometimes even 40 cc's of to 0.25% for some plain blocks like fascia iliaca, and as little as 3 to 5 cc's for the small nerves like LFCN, radial, ulnar, etc. The most important point here is to calculate your maximum dose per patient and avoid local anesthetic systemic toxicity while giving the adequate block. To summarize all, ultrasonography has greatly improved regional anesthesia. To succeed, understand two-dimensional anatomy, optimize imaging for nerves and structures, guide nerves in real time, deliver local anesthetics accurately, and please always keep a good communication with the team. This ensures effective nerve blocks and enhances patient safety. Lastly, these are photos of our hospital here in Edmundston, serving the northwest portion of the New Brunswick province in Canada. And these are the photos of our beautiful city lays around the San Juan River, full of nature and calmness. I just skipped some winter pictures with the frozen river. Thank you for listening to me today.